presentation is over rotator cuff tendonitis and rotator cuff tears. For the anatomy, the rotator cuff is made up of the sits muscle group. This group is composed of the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. The action of the supraspinatus is to abduct the shoulder and stabilize the head of the humerus in the glenoid cavity. It originates on the supraspinous fossa of the scapula. It inserts on the greater tubercle of the humerus. The nerve that innervates this muscle is the suprascapular C4, C5, and C6. The action of the infraspinatus is to laterally rotate the shoulder, adduct the shoulder, and stabilize the head of the humerus in the glenoid cavity. It originates on the infraspinous fossa of the scapula. It inserts on the greater tubercle of the humerus. The nerve that innervates this muscle is the suprascapular C4, C5, and C6. The action of the teres minor is to laterally rotate the shoulder, adduct the shoulder, and stabilize the head of the humerus in the glenoid cavity. It originates in the upper two-thirds of the lateral border of the scapula. It inserts on the greater tubercle of the humerus. The nerve that innervates this muscle is the axillary C5 and C6. The action of the subscapularis is to medially rotate the shoulder, stabilize the head of the humerus in the glenoid cavity. It originates on the subscapular fossa of the scapula. It inserts on the lesser tubercle of the humerus. The nerve that innervates this muscle is the upper and lower subscapular C5, C6, and C7. Pathology of rotator cuff tendonitis. Tendonitis typically occurs from an excessive physical stress that has been placed on the tendon. This causes swelling and inflammation of the rotator cuff tendons and the surrounding bursa. Pathology of rotator cuff tears. A tear of the rotator cuff typically occurs from the chronic physical stress and/or excessive use that causes degeneration. The tear can occur in two different ways. A partial tear, which is the type of tear that damages the tendon but does not completely sever the tendon, and a full thickness tear, which is the type of tear that separates the tendon from the bone. With a full thickness tear, there is basically a hole or a slit in the tendon itself. Mechanism of injury for rotator cuff tendonitis. Poor posture, repetitive tiny shoulder movements, which is seen to be common in office jobs, rounded shoulders, repetitive frictions, and overuse. Mechanism of injury for rotator cuff tears. Falling, consistently pushing off with your arms, like when getting out of a chair. Overuse, repetitive reaching, forceful overhead movements, trauma, and slamming shoulder. Signs and symptoms of rotator cuff tendonitis. Pain, swelling, clicking sounds within the shoulder, stiffness, and a loss of strength. Signs and symptoms of rotator cuff tears. A crackling sensation when moving the shoulder, difficulty lifting the shoulder, difficulty rotating the shoulder, stiffness, a loss of muscle, a noticeable weakness and pain. Special tests for rotator cuff injury, the empty can test or supraspinatus test.
Welcome back to physiology. In the 1970s and 80s, Peter coined the term subacromial impingement syndrome. According to his theory, impingement occurs on the tendinous portion of the rotator cuff by the coracoacromial ligament and the anterior third of the acromion. We have made an elaborate video on this topic that check out later by a click on the link in the top right corner. According to a systematic review by Hedges et al. In 2012, the empty can test had a sensitivity of 74% and specificity of 30%, which would only minimally alter the post-test probability of subacromial pain syndrome, which is why we give it a weak clinical value as a standalone test. To conduct the empty can test, the patient is in standing or sitting position. The arms of the patients are elevated to 90 degrees in the scapular plane. The arms are then fully internally rotated so that the thumbs point towards the floor. The patient is then instructed to resist downward pressure applied by the examiner. The positive test is indicated by weakness and or pain of the affected arm compared to the unaffected side.
Special test for rotator cuff injury, the drop arm test.
In this video, I'm going to show you how to do the drop arm sign to diagnose full thickness rotator cuff tears. Hi and welcome back to Physio Tutors. According to a study done by Miller et al. In the year 2008, the drop arm sign has a sensitivity of 73% and a specificity of 77% in the diagnosis of full thickness tears of the supra and infraspinatus tendon. The post-test probability of a full thickness tear is therefore only moderately altered, which is why we assign this test a moderate clinical value. To perform the drop arm sign, have your patient in standing or sitting position and bring the affected arm into 90 degrees of abduction and external rotation passively. Then tell your patient to hold this position and release your supporting hand. This test is positive for full thickness tears of the supra and infraspinatus if your patient is unable to slowly control the downward movement. Thus the name drop arm sign.
Special test for rotator cuff injury, the Gerber's lift-off test.
This is going to be a video on the lift-off sign to assess for weakness or lesion in the subscapularis muscle. In the literature, different values are reported for its accuracy regarding subscapularis tendinopathy. So check out the table right next to me to see what different authors have to say for the sensitivity and specificity of this test. To conduct the test, have your patient standing with the dorsum of his hand against the mid-lumbar spine. Then ask your patient to lift off the hand from the back and watch for abnormal motion of the scapula, which could indicate scapular instability. If the patient is unable to do so, this indicates a lesion of the subscapularis. If the patient is able to lift off the hand from his back, you can give resistance to test for the muscle strength.
Predisposing factors of rotator cuff tendonitis, repetitive activities, heavy lifting, overhead jobs, overhead sports, the elderly, medical comorbidities such as hypertension, and smoking. Predisposing factors of a rotator cuff tear, the elderly, male, heavy labor, a history of trauma, dominant arm usage, overhead jobs, and overhead sports. Recognition of rotator cuff injuries, the use of special tests, medical imaging such as X-ray and MRI, but you will find that the MRI is most commonly used, the location of the pain, any abnormal sounds with the shoulder movement, the severity of the pain, and weakness of the shoulder. The key factor to recognize the difference between a rotator cuff tendonitis and a rotator cuff tear is through their range of motion. With tendonitis, they will typically be able to move through their full range of motion, whereas with a tear, they can only exhibit partial range of motion. Differential diagnosis for rotator cuff injuries: impingement, degeneration, AC joint conditions, instability, neurovascular conditions, scapulothoracic dyskinesia, muscle ruptures, and fractures. Management and treatment for rotator cuff tendonitis. The use of nonsteroidal anti-inflammatory drugs, steroid injections, cortisone injections, physical therapy, the use of modalities such as ultrasound and e-stim. It usually takes 3 to 4 months for a full recovery from rotator cuff tendonitis. Management and treatment for a rotator cuff tear. If the tear is less than 1 centimeter, the treatment would be the same as with rotator cuff tendonitis. If the tear is greater than 1 centimeter, then surgery is required. There's 2 different surgical routes that can be taken for a rotator cuff tear, the arthroscopic surgery and open incision surgery. Physical therapy will be prescribed after surgery. It takes up to 6 months for a full recovery. Referral. As an athletic training student, you will refer the athlete to a certified athletic trainer when you suspect a rotator cuff tendonitis or rotator cuff tear. The athletic trainer will then refer the athlete to an orthopedic surgeon. From there, the orthopedic surgeon will be able to use medical imaging to confirm the diagnosis and will proceed from there with a medical protocol. Immobilization. The traditional sling is typically used when needed with rotator cuff tendonitis. The shoulder immobilizer sling is used after rotator cuff tear surgeries. The rotator cuff compression brace can be used for an ease of pain with rotator cuff tendonitis and rotator cuff tears. Prevention. Strengthening exercises for the rotator cuff muscles. Practicing good posture. Not sleeping directly on the shoulder or sleeping with your arms above your head. Do not smoke. Avoid repetitive overhead activities. Gradually introducing repetitions to strengthen all of the muscles in the shoulder. Practicing low resistance exercises. Practicing arm raises to the side with external rotation, specifically when warming up before your activity takes place. And it's recommended to get frequent massages with heat and cold compressions. Mulligan technique. There is no mulligan specifically for rotator cuff tendonitis or rotator cuff tears, but as an athletic trainer, you can utilize the mulligan techniques of the posterior lateral glide, with or without a belt, and the posterior inferior glide while the patient's in the seated position to help with pain relief. It is important to know that with these mulligan techniques, they do not provide a healing atmosphere for the patient, and they are strictly dependent on the ranges of motion that causes pain to the athlete as well. PICOT analysis. For my population, researchers had conducted 25 studies with 683 current athletes and 176 non-current athletes. The intervention was to determine the rate of return to a sport after the treatment of a rotator cuff tear. The comparison was with athletes who were not able to return to play after they had sustained a rotator cuff tear. The outcome of this study was that most recreational athletes are able to return to sports at the same level of play as before their injury, but only half of professional and competitive athletes return to an equivalent level of play. The time frame for this study was from 3 months to 13.4 years, and it was dependent on how long it had been since the athlete had sustained a rotator cuff tear. Below is my reference. These are the references listed below that I have used to complete my presentation.